Hello everyone, welcome to my channel Surgery Nuggets by Dr. Himashree. Today, let's discuss a very common topic in surgery, that is appendicitis. Appendicitis is the inflammation of vermiform appendix. It is a common surgical condition. Acute appendicitis is most common surgical emergency in case of children. Now let's start with the surgical anatomy. Appendix arises from midgut. The precursor of appendix is cecal diverticulum, which appears at around 6 weeks of gestational age. The appendix can be variable in length, usually 5 to 10 centimeter in size. But here you can see this is the cecum, this is the base of the appendix, and here is the appendix. Now this blue color fold is a fold of mesentery, which is called mesoappendix. So this is mesoappendix. What is the importance of this mesoappendix? This peritoneal fold which is suspended here, it contains the appendicular artery. You can see this is the appendicular artery. Appendicular artery is a terminal branch of ileocholic artery. Ileocholic artery is a branch of superior mesenteric artery. So what do you mean by terminal branch? Terminal branch means those are end arteries. If any obstruction to the blood flow occurs in this artery, then the appendix will be gangrenous. Here we can see the anterior cecal artery, and this dotted line also represents the posterior cecal artery. Now appendix, the mucosa of appendix, it contains numerous lymphatic follicles. Therefore, it is also known as abdominal tonsil. So appendix also known as abdominal tonsil. The appendicular artery, as I have mentioned, it is the terminal branch of ileocholic artery. The lymph nodes drain to ileocholic group of lymph nodes. Autonomic nervous system is superior mesenteric plexus. The afferent fibers, the sympathetic nerve fibers, they enter the spinal cord at T10. This T10 corresponds to the umbilical dermatome. Parasympathetic is from vagus. Now void of tinea coli. And there is no sacculation or appendices epiploiky, that is the fat-filled cavities. Those are not present in appendix. Coming to the next diagram, this is cecum. Here you can see different position of appendix based on the position of tip of the appendix. As we already know, the base of appendix we can trace by tracing the tinea coli. All tinea coli, where the point where they merge is the base of the appendix, but tip may vary. Most common is the retrocecal position. Retrocecal appendix is common, that is 65 to 75% cases are retrocecal in position. Next most common is pelvic, which is around 21% common. Pelvic appendix means appendix tip at the 5 o'clock position. Post-ileal 1 or 2 o'clock position, pre-ileal 1 or 2 o'clock position, and there is also subcecal, that is 6 o'clock position. Sometimes the tip may be subhepatic also. Coming to the histopathology of acute appendicitis. Here you can see there is ulcerated mucosa. This is the ulcerated mucosa. And also, most characteristic feature of acute appendicitis on histology is presence of numerous polymorphs. Now coming to the pathophysiology, appendicitis can be non-obstructive or obstructive. But whatever is the reason, there is basically luminal obstruction. So in appendicitis, the lumen of the appendix is blocked, there will be elevation of pressure in the lumen because of the ongoing mucus production and gas production. This will cause obstructed venous drainage and mucosal ischemia, ultimately leading to perforation. The most common site of perforation is the tip of the appendix. Perforation, localization of the perforated site by greater omentum and dilated ileum may lead to formation of an lump or abscess. Coming to the clinical features, the most common feature is vague abdominal pain, which occurs first. The typical site of the pain is initially around the umbilicus. Usually the pain shifts to right iliac fossa at the McBurney's point. So the visceral pain starts around the umbilicus because of distension of appendix, and later on the somatic pain occurs in the right iliac fossa. Why somatic occurs? The somatic pain occurs due to the inflammation of parietal peritoneum. So next comes nausea and vomiting. And the temperature or fever comes late. So fever seen in acute cases, acute appendicitis cases, they have fever. So this is called Murphy's triad, very important. Murphy's triad means pain followed by vomiting followed by fever. And depending on the position of the appendix, presence of the tip of the appendix, patient may have diarrhea or pelvic pain in case of pelvic appendix. Coming to the examination part, in general examination, patient will look ill. The acute appendicitis patients appear ill. They will have tachycardia, temperature will be increased, or appendicular lump may be felt in right lower quadrant, or sometimes abscess formation also seen. In this diagram, let's see, in this diagram, we have seen what is McBurney's point. So this is anterior superior iliac spine, this is the umbilicus. The line joining the anterior superior iliac spine and umbilicus is called spino-umbilical line. The medial 2/3 of this line, and this is the lateral 1/3 of this line. The junction between medial 2/3 and lateral 1/3 is called McBurney's point. So typically in appendicitis, tenderness is present at the McBurney's point. Now coming to other different signs which are specific to appendicitis are Baldwin sign. Baldwin sign is seen in case of retrocecal appendix. So what happened here, when the legs of the patients are lifted off the bed with knee extended, patient complains of pain while we press over the flanks. So that is called Baldwin sign, and it is seen in case of retrocecal appendix. Next we have Ropsing sign, very important. Ropsing sign means if we press the left lower quadrant of abdomen, pain will be felt over the inflamed appendix because the intestines will push the inflamed appendix. So this is called Ropsing sign because of shifting the bowel loops, which irritates the parietal peritoneum. Next comes Psoas sign, Cope-Psoas sign, seen in case of retrocecal appendicitis. What happens if we hyperextend the right leg? In case of retrocecal appendicitis, in case of retrocecal appendix, it will cause pain in the right iliac fossa. Here you can see we have hyperextended the right leg. Patient is in lateral position. Hip is extended, and it will cause a pain in the right iliac fossa. Next, another important sign is obturator sign. This is seen in pelvic appendix. Here, what we do in obturator, internal rotation of the right hip joint by flexing the knee and externally rotate at the ankle joint. So it will cause the internal hip rotation which will give irritation and cause pain because of inflamed pelvic appendix. These two signs are extremely important. Next, hyperesthesia in Sharon's triangle. So what is Sharon's triangle? See in this diagram, this is the umbilicus and this is the anterosuperior iliac spine. This is the umbilicus, anterosuperior iliac spine, and here will be somewhere pubic symphysis. So these 3 points will make the Sharon's triangle: umbilicus, anterosuperior iliac spine and pubic symphysis. Dunphy's sign. Dunphy's sign means right iliac fossa pain on cuffing. Another important sign is rebound tenderness, also known as Bloomberg sign. In rebound tenderness, if we suddenly release the pressure over the right iliac fossa, patient will complain of pain. Next comes 10-horn sign. What happens here? Pain caused by gentle traction on the right testicle. In sign, Aaron sign means pain in the epigastrium on persistent firm pressure applied to the McBurney's point. Around the stomach, there is pain. Next comes basilar sign, that is sharp pain by compressing the appendix between the abdominal wall and iliacus. These are some of the important signs, named signs seen in appendicitis. Another important term is amient hernia. So what is amient hernia? It is the appendix it is the inflamed appendix within inguinal hernia. So coming to the investigation, in blood investigation with appendicitis, so raised WBC, very important. Then CRP also raised. Ultrasound whole abdomen. If we do an ultrasound, some specific features are seen. Number 1, appendix is non-compressible. It is aperistaltic, fluid-filled and blind ending tubular structure. In some books it is written that more than 6 mm diameter is considered as dilated. More than 6 mm diameter signifies acute appendicitis. In some other standard textbooks, 7 mm is taken as a cutoff. 7 mm taken as a cutoff. Hyperechoic appendicolite can be seen with posterior acoustic shadowing. Single wall thickness of appendix is more than 3 mm in case of acute appendicitis. There is increased echogenicity or fat stranding surrounding the appendix. So these are some of the important features seen on ultrasound investigation. Another important characteristic sign is target sign. What is target sign? It is also known as bull's eye appearance. Bull's eye appearance means there is concentric hypoechoic and hyperechoic layers. So what is the hypoechoic center? It is a fluid-filled cavity, that is hypoechoic center. Then a bright hyperechoic mucosal or submucosal ring is seen. See this last diagram. Here you can see the center is black, then we have a whitish layer, then again one black layer. So this is called bull's eye appearance. The outer dark hypoechoic layer is the muscularis layer. This is another diagram of ultrasound color Doppler. Here you can see in case of appendicitis, the vascularity has increased surrounding the appendix and it gives a fiery appearance, which is very prominent here. This is a normal appendix, but here the diameter of the appendix is increased. A thick. Coming to in different age groups. What are the different possibilities in different age groups? First of all, in adult male, the most common differential diagnosis is acute cholecystitis. Then it can be a case of perforated peptic ulcer also. We have to differentiate it from peptic ulcer disease. Next comes renal colic, which is also very common in this age group. Then acute pancreatitis or diverticular disease. In case of children, what are the differential diagnoses? Most common are mesenteric adenitis. Then comes non-specific abdominal pain, UTI or intussusception. These are common in pediatric age group. Now coming to elderly people, in elderly age group, malignancy should be suspected first. So we have to think about colorectal carcinoma, if vascular disease, or it can be a case of diverticulitis, or sometimes we see there is adhesion because of previous surgeries or exploratory laparotomy. For females in the reproductive age group, PID can be common differential diagnosis. PID can be a differential diagnosis, that is pelvic inflammatory disease. Then urinary tract infection, ectopic pregnancy should be ruled out. We always do a pregnancy test in any pain abdomen case in female. Then twisted ovarian cyst, or sometimes some physiological conditions like Mittelsmarch syndrome. The pain in lower abdomen during follicular stage of menstrual cycle is called Mittelsmarch syndrome. In case of appendicitis, the most commonly used is Alvarado score. So what is Alvarado score? In Alvarado score, we see the symptoms of the patient, then signs, and also lab investigations. Symptoms, then we see the signs and lab investigation. Total score is 10. Tenderness in the right lower quadrant and leukocytosis, score is 2. For others, we give 1, score 1. So what is Alvarado score? First is symptom, migration of pain, nausea, anorexia, nausea. These 3 are symptoms, given 1, 1, 1 scores each. Then comes the sign. This is symptom. Then comes the sign. What is the sign? Tenderness in right lower quadrant, 2 score. Rebound pain, 1. Elevated temperature, patient will have fever, that is 1. These are the signs. Next come lab investigations. So what are the lab investigations? I already mentioned leukocytosis is common. So leukocytosis we give 2. Shift of white blood cell count to the left, immature blood cells, those are given 1 score. So total score comes to 10. Now if patient have 1 to 4 score, that means it is unlikely to be appendicitis. We discharge the patient. Score is 5 to 6. We have to observe or admit the patient and observe. 7 to 10 means definitely it is a case of acute appendicitis and we should go for surgery. So what is the predicted number of patients with appendicitis? From score 1 to 4, 30% may have appendicitis. Score, if it is 5 to 6, 66% around will have appendicitis. If the score is 7 to 10, almost 93% may have appendicitis. Scoring system is appendix. Another scoring system is appendix inflammatory response score. So what is AIR score? Here we stratify the patient into certain risk groups. Vomiting, second is pain in the right iliac fossa, score 1, 1. Third is abdominal defense. If it is low, 1, mild 2, severe 3. Next is temperature, if fever is present, 1 score. Next comes segmented neutrophil, 70 to 84% 1, more than 85% 2. Next comes leukocyte. If leukocyte, depending on the leukocyte number, it is given 1 or 2 scoring. Then comes the CRP. CRP less than 49 is 1, more than 50 is score 2. So the sum total, if it is the sum of this is 0 to 4, low probability of appendicitis, 5 to 8 is mild probability, 9 to 12 is high probability. This scoring system also take into account the demography. Male or female, they are given different scoring system. Age is given different scoring system. More than 40 years is 0.5. And again, we have taken for in NRIC is 1. Okay, so demography is taken here along with the clinical signs, symptoms and laboratory investigation. If score, Ripasa score less than 5, it is unlikely acute appendicitis. If score is 5 to 7, there is a probability that is there is a probability of acute appendicitis. Score 7.5 to 11.5, high probability of acute appendicitis, and score more than 12, definite acute appendicitis. So this is Ripasa score. Only difference is the demography. Okay, demography. Now another system I have mentioned here. This is important in pediatric age group. So this is called PAS score, pediatric appendicitis score. Because children, they may not be able to give you proper history regarding pain. Right lower quadrant, here they have taken the criteria that right lower quadrant tenderness is to percussion, hopping or cough. If yes, then 2 score. If no, then 0 score. The scoring system is a bit different than adult population. If there is less than 4 score, that is called low risk category, low likelihood of acute appendicitis, and they likely do not warrant imaging. If score is equivocal, 4 to 6 score in PAS system, then imaging is done, ultrasound or MRI. Surgical consultant may be warranted. If it is high score, more than 6, surgical consultant is taken. Coming to treatment part, let's have a brief overview of the treatment. If it is an acute appendicitis case, then we should go for emergency laparoscopic or open appendectomy. If it is a recurrent appendicitis, previous history is also there, then we go for elective lap or open appendectomy. Sometimes patient comes after 3 to 5 days. So within 3 to 5 days, appendicular lump formation occurs. In that case, we cannot operate. We go for, but if on Ochsner-Sarin regimen, patient deteriorates, then we have to go for emergency appendectomy. Some cases will have appendicular abscess. They are drained by USG, they are drained by ultrasound or CT guided aspiration, and broad spectrum antibiotic coverage given, and interval appendectomy done for appendicular abscess or lump cases. You can see the different incision used for open appendectomy case. The basic incision is McBurney's grid iron muscle splitting incision. So what's perpendicular to the McBurney's point? That is medial 2/3 and lateral 1/3 of spino-umbilical line, that is McBurney's point, and perpendicular to this point is the muscle splitting grid iron incision. Another incision is lens. Lens incision is also known as modified McBurney's, that is horizontal and more cosmetic incision. Then comes the Fowler-Weir approach, that is medially cutting the muscle over the rectus. Another incision we have given is the Rocky-Davis incision or lower middle. Other incisions are Rocky-Davis incision or lower midline. Lower midline incision are more favorable in case of abscess or appendicular lump cases. Okay, then come to laparoscopic appendectomy. For laparoscopic appendectomy, the placement of port depends on the position of appendix. Usually, we put a 12 mm port, umbilical port, then 2 5 mm ports. But the position of the 5 mm ports will depend on the position of the appendix. We may modify it. I am showing how laparoscopic appendectomy is done. And the last one is a single incision laparoscopic surgery. This is single incision laparoscopic surgery. Step-by-step procedures I'll discuss in some other videos. The steps of open appendectomy and laparoscopic appendectomy I'll discuss in some other videos, not here. Ochsner-Sarin regimen. So what happens here? This is a conservative approach for patients with appendicular lump. After around 3 days of acute appendicitis episode, patient will form a lump. Why lump is formed? Because now it is a body's defense mechanism. The greater omentum will come and cover the inflamed appendix. The greater omentum, dilated cecum will cover the inflamed appendix so that it can localize the infection. Localize and prevent the infections from spreading to surrounding structures. So there we will find a lump on palpation. What we do here, we keep the patient NPO. And put a Ryle's tube. So nasogastric tube decompression is done. Then broad spectrum antibiotics are given. For example, ceftriaxone 1 gram IVBD and metronidazole 500 mg IV TDS. Injectable analgesics are given. Then injectable analgesic are given. PPI, IV fluids are given. Monitoring, we measure pulse, respiratory rate, BP, 4-hourly monitored. Size of the lump is marked twice daily. We have to see whether lump is increasing or decreasing in size. We have to mark it twice daily. Parabdominal examination for any features of peritonitis. So parabdominal examination means, is there any guarding or rigidity? So we look for guarding or rigidity to rule out peritonitis, perforation peritonitis. Total counts are measured daily, and if patient is responding well to ostenosaline regimen, we can continue this, and interval appendicectomy is done after 6 to 8 weeks. But if for some reason patient is deteriorating, there is signs of peritonitis, tachycardia, patient is in shock, then immediate emergency appendicectomy is done. So what are the complications of appendicitis? Even before surgery, if we are not operating it, sometimes what happens, there may be perforation of the appendix. It will perforate, leading to peritonitis and finally to septic shock. Next comes abscess or lump formation. I have already mentioned. Sometimes fistula are also seen. Mucocele of appendix, small bowel obstruction, paralytic ileus, portal pymia or relapse. So what is portal pymia? Portal pymia can be seen both preoperatively and postoperatively also. So portal pymia, what happens here, there is a but life-threatening condition where an infected emboli from perforated appendix may travel through the mesenteric veins through the portal circulation. So that is called portal pymia. Then complications are wound infection, reactionary hemorrhage, that is slipping of the ligature. There may be slippage of the ligature. Intra-abdominal abscess, stump appendicitis. It's fragile, we may perforate cecum accidentally. That can also lead to fecal fistula. So this much for today. Thank you. Subscribe to my channel and share for more such videos. See you soon.